Good afternoon, everyone. I am Marissa Hassan, Program Manager for the South Carolina Coalition for the Care for the Seriously Ill. We are absolutely thrilled that you are joining us on the fourth day of our virtual symposium. It is the grand finale. Listen, we have had an amazing week this week. Every day, we're taking a deep dive into our theme, collaborating to transform cancer care. Dr. Christina McDaniel kicked us off on Tuesday, really talking about how oncology, we can integrate palliative care with oncology and the steps that they've taken at MUSC to do that, which has been, I love the fact that she kept it simple and then gave a lot of us hope about, how to just get started. Don't worry about how big or how small, but figure out where you want to get started and get that senior leadership buy-in. And then, of course, on Wednesday, we really talked about looking at the various ways that we can provide adult and pediatric um, oncology care. And our experts really showed us from survivorship to pediatric care to really looking at different ways to enhance just the health and the quality of life through various modalities. Particularly, I was interested in the physical activity that was shared about the pediatric camps, and then the child life specialist piece in terms of how play therapy really helps our patients. And then on yesterday, oh my goodness, we had the caregiver lens, where we really looked at the impact of care really from the caregiver's perspective. And really, there were so many things that really stood out to me, but our speakers on yesterday, we had a caregiver who was so vulnerable and open about her journey and her daughter, Lauren, who actually died from her cancer illness. And she really shared about what that journey looked like and how she became an advocate. And through her advocacy, she really underscored the need to start palliative care early with pediatric patients. And I will quote Amy as saying these words: the oncology team is thinking about how to get us through tomorrow, but the palliative care team is thinking about how to help us today. And man, that was very, very powerful. Chrissy also said something that was interesting. She said, I realized in my research that I needed to listen to the caregiver's voice, and I began to hear them in a different way. And then also Tiffany, who is a pediatric cancer survivor and works with the American Cancer Society as a person who does a lot with the health systems and helping them with the work that they do and supports and resources and partnerships, et cetera. So we had a candid conversation. And I also love the fact that Kari on yesterday, our moderator, really opened up about her own personal experience with her twin daughters and how just the thought that every 3 months, because of their condition, they're at high risk to have a pediatric cancer in their ages, and what that meant. I'm not just a medical director of an agape program, but I'm also a mother, and how often we are as clinicians, we are also caregivers to our own family members at times, and what that looks like. And so, listen, today is going to be special. I'm not going to spill the tea on it because Lauren's going to set us up for it. But I want you to know that it's been a wonderful week. And if I teased you with what we talked about, guess what? We've got recordings of every single day, and we'll be sending those out to everyone. Also wanted to let you know that we want your feedback. Every year we do this virtual symposium in the month of April, which is also Healthcare Decisions Month. And so this month, of course, the governor's proclamation has gone out. Many of you are doing work in communities where you're helping community members think about how to begin to have these conversations sooner, as opposed to waiting till there's a medical crisis and someone's in the ER and you absolutely feel the pressure and you're not sure what your loved one would want. So we're very engaged in helping clinicians on how to have those conversations through post, our work through the coalition. We do a lot of advocacy around post. And our latest project is really to look at how we can, in South Carolina, consolidate the healthcare power of attorney and the living will into one document. We have so many documents in our state, EMS DNR form, the post form, the living will, and the healthcare power of attorney. So we are going to be working on some advocacy related to that. We've been in existence since 2010. In addition to that, we are looking at palliative care across the state and what can we do to ensure that what the great work we're doing with palliative care shows up on the CAPC palliative care scorecard. So we are absolutely working that when the next report card comes out, we will find ourselves in a different position in terms of the national ranking. So very thrilled about that. If you're interested in participating with us in any of the things that we're doing, we meet once a month on the third Wednesday of the month from 2 to 3:30. We always have a topic where we're diving into the serious illness care continuum, things that are relevant for the work that all of our clinicians are doing. And we certainly want to encourage you to join in and connect with us as we are doing that work. We're made up of health systems, clinicians, community stakeholders. We've got them all. And so we invite you to connect with us. There's no membership fee. You just jump in and fit in where your passions are. And we absolutely welcome you to do that. Now we're getting ready to move into today's session. And I want to introduce to you our moderator, Lauren King. Now, Lauren is not just an LMSW. Listen, she is a clinical assistant professor at the internal medicine with USC. So she definitely carries the big stick because she's training other people, right? She's also a part of the ethics committee there at Prisma. And listen, she's also one of the lead individuals who helps to coordinate and plan the annual Hospice and Palliative Care Conference that is sponsored by Prisma, which we had an amazing one that they hosted last month, and they do this every year. So we're in good hands, Lauren, and I am absolutely going to turn the driving over to you now. Thank you.
Thank you, Marisette, for the introduction as well. Good afternoon, everybody. Again, I'm Lauren King. I am a palliative care social worker here at Prisma Health. I have been a palliative care social worker now for about 18 years. The entirety of my career has been spent in the space of hospice and palliative care. So I'm really glad to be here, especially today's session, which is going to bring us into a space that we all encounter in clinical care, but don't always name clearly: the complexity of pain, not just as a physical symptom, but as something that touches every part of a person's experience. In cancer care, especially, pain rarely exists in isolation. It's shaped by the body, but also by identity, by relationships and meaning, and the uncertainty that comes with serious illness. What we often see is that when one dimension of pain is left unaddressed, it amplifies the others. As a social worker and as a palliative care team member, I often have the privilege of sitting in that in-between space where physical symptoms intersect with emotional, social, and spiritual distress. It's in those moments where that we're reminded that pain isn't just about what's happening to the body, but what's happening to the person. So today we're fortunate to hear from two experts who will help us explore these different but deeply connected dimensions of pain. One from the perspective of cancer-related physical pain and its management, and the other from the lens of spiritual pain, how disruptions in meaning, identity, and connection shape the experience of suffering. So it's my honor to introduce Dr. Judy Pace, PhD in RN. Dr. Pace is the director of the Cancer Pain Program at Northwestern University Feinberg School of Medicine and a research professor of medicine, a past president of the American Pain Society and contributor to the NIH HEAL initiative. Her work focuses on cancer pain relief. She also has been a leader in the End-of-Life Nursing Education Consortium and has educated clinicians worldwide on pain management and palliative care. I'm also going to introduce Michelle because after Judy gives us her presentation, we're going to move into Michelle's presentation before we do into a panel discussion. So Michelle Robinson is a manager of spiritual care and education and ethics chair at Prisma Health Midlands Hospitals in Columbia, South Carolina. She holds a bachelor's degree in English and a master of divinity and completed a chaplain residency with Prisma Health. With 7 years of hospice experience, she is also a certified educator and a healthcare ethics consultant. Michelle's passionate about supporting patients, families, and clinical teams throughout compassionate ethical care. So as we move into a space where Judy is going to present for us first, I want you to, as you listen, invite you to consider where do these perspectives overlap in your own practice, and where might there be opportunities for us as interdisciplinary teams to respond more fully to the patients that we serve. We'll have time for discussion after both talks, and I'm looking forward to exploring these connections together. So with that, I turn it over to Judy. Thank you.
Lauren, thank you so much for that introduction. Hope I can live up to it. And Marisette, thank you so much for the invitation today. And I'm really excited to be speaking with Michelle. This is going to be a very busy and a lot of interesting information for a relatively brief time period. So I'm going to be focusing on challenges in cancer pain management. And I think you'll see that this probably transcends, for those of you who are in palliative care taking care of people with other serious illnesses, you're going to see that this transcends just oncology. So what I'd like to do for you today is to define some pain syndromes seen in oncology, because for some of you, if you have a little gray hair like I do, the syndromes have really changed over time and they're evolving daily. We're going to integrate that biopsychosocial models, biopsychosocial spiritual model, because that's really what drives my clinical practice. And I find it to be an extraordinary foundation. And will lead very nicely, I believe, into what Michelle's going to be discussing. And then we're going to talk about the pros and cons of different treatment options. So you all know that cancer-related pain is quite a serious phenomenon. And these are some global data. The bottom line is we need to assess and we need to believe the patient and their loved ones when they report. And then we investigate further. We need to consider that for people undergoing treatment, pain is not uncommon and it's more than 50%. And then those who have advanced disease with more tumor burden are more likely to have significant pain prevalence. And where does that pain come from? Well, we see pain due to the cancer itself, and pain due to the treatment, and then pain that's unrelated to cancer and its treatment. I have many patients in my outpatient practice. I follow about 180 patients. About 90% are people with cancer. The other 10% or so are people with sickle cell disease and hemophilia, and most of my hemophilia patients are also HIV positive. The prevalency rates are going to change based upon where you're practicing, the age of the patients, the treatment regimen that are being employed, the gender of your patients. So all of these are going to alter these prevalency rates. So nothing is really carved in stone. So what I'd like to do is to give you a very quick overview of the pain related to cancer treatment, because most of us in a palliative care and in a hospice setting, we understand the pain related to the cancer itself. It's producing a mass effect. It's pressing against either hollow organs or against bone, against nervous tissue. These pain syndromes that we see related to treatment are a little bit more unique. So fasten your seatbelts because I'm going to go really quickly here. Obviously, you've all heard about and known about pain syndromes related to surgery. We've known about it from even before the time of the Civil War, when people were having amputations in the battlefield and phantom pains were being described. And we see phantom pains. I have several patients who have sarcomas where unfortunately limb sparing procedures were not effective or possible. And so some have four-quarter amputations, other have less extensive amputations, but phantom sensations can be extraordinarily common. And that's not all. We see post-mastectomy syndrome, post-thoracotomy syndrome. And what's really unique is that even with the minimally invasive procedures that are really becoming much more prominent and the robotically directed procedures, we are still seeing painful syndromes, not just the acute pain, but with persistent pain. Now, radiotherapy related pain syndromes, I think, is a true success because as a new nurse a billion years ago, we saw such extraordinary acute and then chronic syndromes. We would see horrible desquamation in the treatment fields. And now we are using very low dose corticosteroids in the treatment area and lots of aquaphor and other kinds of emollients that are keeping the skin moist and preventing the redness and the pain and the quality of life problems that would occur. When women would come in after breast cancer radiation, they couldn't even wear a simple t-shirt because they had such severe allodynia. The touch of the cotton fabric was painful. I saw many with fistula formation and individuals with osteoradionecrosis and fractures and neuropathies. Now, this x-ray on the right is a patient that I cared for, and it's been a while ago now, but it is such a profound case. This woman was treated for cervical cancer, first with radiotherapy and a minimally invasive surgical procedure. Unfortunately, she recurred, more chemo, radiation, more surgery, and she was cured. But long term, you can see the complications. Bony complications. She needed a total hip replacement. And really, you can see she needed it on the other side as well, but just could not go through the surgery. She had an ostomy because of fibrosis and obstruction. And she had stents placed in the ureters. Those weren't sufficient. And she ended up having nephrostomy tubes. This woman ran out of money to provide care for herself. Her adult children came to live with her. One got a job working nights so he could be there during days. The other had a job during days so she could be there during nights. We did not have medical aid in dying at that time. It's actually very new in Illinois. And she wanted to end her life. We had numerous psychiatric assessments. Palliative care was very involved, and she decided to stop eating. And after about 2.5 weeks, she did die. She just simply could not live with all of the changes to her body and the severe pain that she was experiencing. But as I mentioned, the good news with conformal radiotherapy is we are seeing far fewer of these long-term complications. Now, chemotherapy produces peripheral neuropathies, and we see many bony complications from all of the corticosteroids that we use, compression fractures, avascular necrosis, and others. Immunotherapy, still pretty new on our agenda for oncology treatment, and so we are still learning about the inflammatory arthritides that we're seeing, myositis, polymyalgia-like syndromes, and peripheral neuropathy. Now, in the past, these patients had a limited lifespan. Again, I remember as a brand new nurse taking care of someone with stage 4 melanoma, and now we are seeing cures with immunotherapy. And same thing with some of our stage 4 lung cancers, where people died in less than 6 months, and now they're living 5, 6, or more years with a good quality of life. So we're seeing more of these long-term complications. Our breast cancer and prostate cancer patients are treated with various hormonal agents that can produce arthralgias, dyspareunia in our female patients who have aromatase inhibitors, where it is blocking estrogen formation, leading to dryness and painful intercourse. And also then urinary symptoms, which can be actually quite debilitating and fatal if sepsis occurs from a urinary tract infection. So these are not trivial, oh, go take an ibuprofen and feel better. Gynecomastia can occur in our male patients, and not only is it painful at times, but it also alters body image, myalgias, and then again, osteoporotic compression fractures. Our patients who have myeloma, lymphoma, um, leukemias, who are undergoing stem cell transplant. And now, by the way, we're seeing this with sickle cell disease and other autoimmune disorders. But in the oncology arena, we see it often where individuals have had an allo transplant. In other words, they didn't get their own cells reinfused, they got a donor cell. And what we're seeing is it's very different than when someone gets a solid organ transplant, where our body rejects the organ. With stem cell transplant and GVHD, or graft versus host disease, the cells that have been infused are rejecting the body. So it can affect, the GVHD can affect every organ system. And in fact, here's a graph that really outlines how the skin can be affected. We can see hyper and hypopigmentation, lichen planus. I will see patients who look like they have a scleroderma or a severe burn, and it can be painful. They have reduced range of motion, itching in the mouth, again, lichen planus, ulcers. This can impair our intake of food, certainly our enjoyment related to food. The eyes, patients tell me every time they blink, it feels like the back of their eyelids have sandpaper on them. In the esophagus, we can see strictures, difficulty with swallowing, and food just doesn't seem to want to go down, heartburn. The intestines will see intermittent small bowel obstructions, diarrhea, more nausea. And musculoskeletal issues can produce arthralgias and myalgias and weakness. We see pain when the nervous system is affected, hematuria with the uro system, and then I'll see patients with severe vaginal pain and dyspareunia. So that's a little bit about GVHD, and now here's another big question mark. We've really just started using CAR T in the last very few years. What are going to be the long-term complications that we see as a result of these treatments? And honestly, patients in my institution, at least, who are getting CAR T have always been heavily pre-treated with a variety of chemotherapeutics and immunotherapy, and in many cases, stem cell transplant. And so it is a perfect storm of complications, and many of these are painful. I also need to point out that many of our patients have been so pre-treated with agents that are altering the immune system that I've been seeing several patients who have survived CAR T, and a year later they're diagnosed with yet another cancer. I just had 2 myeloma patients last year diagnosed and died from pancreas cancer. So we must always keep on our differential diagnosis. Is it possible that they may develop another cancer? Is that what this pain, this new pain, is arising from? So I've just shared with you a lot of painful syndromes. Some of you may be thinking, but wait, why is this different than anything else besides some of these unique syndromes? Well, I do think that cancer pain is very different. And part of it is the trajectory that our patients are on. And Debbie Mayer is a nurse who I really value this map. And it's really complicated, and yet it really describes the course for many of our patients. They're diagnosed, they are given treatment with intent to cure, and some are going to have long-term cancer-free survival. Others are going to have recurrence or long-term maintenance therapy. Some are going to then enter into that algorithm of palliative treatment. And some of our patients from the beginning are in palliative treatment. And that's always a concept that's very difficult for our patients to understand. There's always hope. There's always a question mark. And so what's very different in my mind about cancer therapy is the uncertainty, the question mark. I have 3 ladies right now who have been treated successfully for their pancreas cancer with Whipple procedures, but all 3 presented with severe pain and had to really fight to get those scans, to get the diagnosis. And so as they are facing chronic pain, because Whipples are really devastating surgical procedures, often leading to chronic abdominal pain, there is just this light bulb that goes off for them. Is this chronic pain, or is this my cancer coming back? So this is what guides my clinical practice: the physical, psychological, spiritual, and social consequences or contributors to pain and suffering. And yes, pain and suffering are different, and yet there is tremendous overlap amongst the two. So as I'm doing my physical assessment and my history and intake on patients, I am really asking questions about each of these components. Is this a more physical component? Tell me more about where is the pain located? What does it feel like? What does this pain do for your mood? How is your mood? Are you feeling sad? Are you feeling distressed? Are you a faith-based person? Is that community helpful to you? And I'll certainly let Michelle talk more about that. But I ask everybody, what gives you strength? What helps you through these difficult times? And for some people, often it's family. For some people, it's faith. And when I'm faced with a patient who can't tell me, then I know we need to really boost up their resources. And of course, the social implications of pain. What are you able to do and not do because of the pain? So many of my patients say, I used to be able to go out with my retired friends and we would do silver sneakers, and I can't do that now. Or I used to be able to go to church and I loved the community, and I can't do that now. Or I can't go to a restaurant and sit. So when I ask patients, what if we could do a better job with your pain, what will you be able to do? And some of my patients with cure will say, I want to go back to work. And some of my patients will say, I want to be able to participate in physical therapy, but it's too tough right now. And for some of my patients, it may be, I want to be able to walk my dog, or I want to be able to hold my grandbaby. So we implement a regimen, and when they come back a week, 2 weeks, were you able to hold your grandbaby? Were you able to walk around the block? And if not, why? Was it deconditioning? Well, then let's get you some physical therapy. Was it pain? Let's figure out how to tweak your regimen. So how do we manage pain? You all know, you are all skilled clinicians. So we have, in our very brief time together, I'm just going to basically focus on the medication therapy. Basically, we have the non-opioids, which are acetaminophen and the non-steroidals. And I'm going to be honest with you, I'm finding these are overused in the world of opioid stewardship and fear of opioid misuse. So NSAIDs, remember, have significant adverse effects, especially in our population of seriously ill. Renal compromise, GI bleeding, and increased risk of stroke and MI. Acetaminophen, we used to just think about liver compromise, but now we know with long-term use, they can also affect the kidneys. So that leads us to the opioids. And of course, the adjuvant analgesics, which are highly important for our neuropathic pain. So I was asked to be a co-chair with Eduardo Barrera from the MD Anderson Cancer Center. And we were asked by ASCO, the American Society of Clinical Oncology, to come up with a clinical practice guideline on the use of opioids for adults with pain from cancer and its treatment. And we put together an interdisciplinary panel, and we did a systematic review of thousands of pieces of literature. And these were only the best papers, systematic reviews, randomized controlled clinical trials. And we went back really far. And we answered 7 questions and provided 16 recommendations. Now, for those of you in palliative care and hospice, you are not going to be surprised by these, but I want to share with you some of our findings and some of the nuances or newer findings. So when do you use opioids? Moderate to severe pain. And I'm going to be frank, I've got a few patients who have less than moderate pain, but they can't take any of the other agents because their kidney function is impaired and they have a significant risk of cardiovascular disease. So I might use baby doses of an opioid. But for most patients, it's when the pain is moderate to severe. And what's different? When you start an opioid, you discuss the goals. The goal is not zero pain 24/7 so you can lie on the couch and watch TV. The goal is function, be able to do something, to return to some level of quality and activity. And we set these expectations. Intensity is no longer really our outcome, even though in the hospitals, Joint Commission is still asking us to rate the pain on a 0 to 10 scale. It's function that I use as my outcome. And when we talk about expectations, I use that palliative care. I wish, I worry, I wonder. I wish we could give you pain relief that was 0 24/7. I worry that to do that, we would totally cause you to be sedated and it would not be safe. I wonder if there are other goals we could look towards. Then we look at the different opioids, and honestly, the always the opioids on a population level, as we looked at these thousands of papers, there was no difference on a population level. However, you know that patients have different responses individually. I might have one patient who says, morphine makes me really sedated, oxycodone helps. Another patient will say, oxycodone really activates me. I can't take it in the evening or I won't sleep. So we listen to the patient and we get a very good history. What have they tried in the past? What caused adverse effects? It's also a great opportunity for education because many patients will say, yeah, I threw up. That's not really an allergy. That is a very common response when first exposed as an opioid naive individual. So as I'm selecting an opioid, I look at their past history and I think about the bioavailability. Do they have severe renal disease? That's going to lead me to look at different agents. What about the route? I take care of a lot of patients with head and neck cancers. They're going to need liquids. What are the high intensity liquid formulations that are available? I have high intensity morphine and oxycodone, so I'll think about those. We did call out methadone being a great drug. However, it's complicated and we recommend a consult to palliative care. We also called out tramadol and codeine as agents that you likely want to avoid. That tramadol is a very weak opioid. It lowers the seizure threshold. It has a ceiling. And in early clinical trials, it caused a lot of falls in older adults and in frail individuals. We also called out codeine as a drug to be avoided. And the reason for that is codeine is metabolized through the cytochrome P450 system, particularly an enzyme called CYP2D6. And that enzyme is genetically determined such that about 10% of Caucasians, 3% of African Americans, and 3% of Asian Americans are poor metabolizers, and they can't break down codeine. And so, does anyone remember what codeine breaks down to? Morphine. So they can't get analgesia. So avoid those compounds. Initiate, start low, go slow, use breakthrough medicines. The breakthrough medicines should be somewhere around 5% to 50% dose increases, and then the breakthrough is 5% to 20% of the daily morphine milligram equivalents. And then we rotate when we can't get good pain control despite escalation, or if we have serious adverse effects that we just simply cannot prevent or relieve. And then, unfortunately, I'm going to be honest with you, often I am rotating because of insurance companies. And then something that's very different in oncology compared with my early career, and that is we have people who are cured. So we get them through some painful treatments and then we wean. If someone's only been on an opioid for a week or two, like in a hospital setting or a very acute kind of setting, you really don't need to wean in most cases. But chronically, if someone's been on an opioid, particularly higher doses for longer periods of time, we need to go slow, explain to patients why we're weaning. We optimize the non-opioids if we can, and we don't add benzos or other agents that are dangerous as well. And we do a lot of coaching. Please be aware these are a lot of the obstacles that our patients are facing. And this is what I face every day with my patients and try to obviate. And it has gotten more and more and more challenging daily. So shortages. Most of the opioids we use are generic. And if something happens with the supply chain, they don't have a huge incentive to fix it. You notice we never have shortages of Viagra, but the companies don't make a lot of money off of these drugs. So trying to navigate that, prior authorizations, I don't even want to use the words that I want to say to you when I'm talking with these insurance companies. It is so awful. There are companies now that have developed algorithms that actually are calling out our patients. And they won't tell us what's in these algorithms to develop these risk scores. We do know one of the variables is how many different prescribers have ordered the medication. Well, in an oncology setting, there might be the oncologist, the APP, or more than one APP ordering that medicine for a patient. So patients are being identified as high risk, and it's not fair. Opioid stewardship is important. We did go overboard with prescribing 10 or 15 years ago. But now opioid stewardship means anything but an opioid. And in fact, what I'm seeing from patients in my hospital and many hospitals around the country, everybody is discharged on cyclobenzaprine, which is a muscle relaxant, even on people who don't have muscle-related pain. And we're seeing gabapentin, which is fine if someone has nerve pain, and lidocaine patches, just so that they don't have to prescribe a low dose of an opioid. And the consequence of that is that our trainees are not getting educated on how to use opioids appropriately. And then people are very fearful of regulatory oversight. So there are whole practices of primary care and even pain clinics that won't prescribe opioids. I did not have time to really address non-drug therapies, but believe me, I am always considering this entire list and others as I'm providing care for patients. It isn't just drug therapy. So as we address that biopsychosocial spiritual model, we address all of these other interventions, and it takes a team of patients and families at the core. And again, I know I'm preaching to the converted for all of you in palliative care and in hospice, but as I talk with my oncology colleagues and others, I want to remind us all, one person can't do this alone. It's all of us combined. So I went through that very, very quickly, and I can't wait to hear Michelle's comments and then your comments and questions as we proceed. So I am going to stop the share, and I am going to look forward to Michelle. Thank you.
Thank you so much, Judy. I'm looking forward to the discussion shortly after. We'll let Michelle get set up and have her share her screen and get spotlighted for our next segment.
All right, Lauren, can you see that?
We can see the editing screen, not like the presentation screen, but we can see your screen. Now, I'm seeing the presenter view.
Well, I don't know how to switch that because it's on the, I have a double screen computer and it's swapped how it should be. Let me see.
There should be a menu item near the top of your screen where it says display settings. Take a drop, do a drop down there. One more to the right, display settings.
Down here?
No. Back up at the top where you were, just over to the right by one tab. Okay, now go to the right from there.
All right.
And then it should say over a little bit farther where it says display settings.
So you have 3 tabs at the top: show taskbar, display settings, and end slideshow. It's what we're seeing on the screen.
My screen looks different than what you're seeing, so I'm just not seeing what you're seeing. Let me see.
If you go to the right from right where you're at now, keep going to the right.
Yeah.
Keep going.
Is it under the share? How it's sharing? Nope. Well, I'm sorry. I've gotten really used to using Microsoft Teams. I used to be an expert at Zoom, but I haven't used like 2 or
Yeah,
3.
it's just weird that you're not seeing what we're seeing. Above the slide that says pain management and holistic therapies, we see 3 tabs at the top. We see show taskbar, display settings, and end slideshow. Do you see those 3 tabs up there?
No, I see show taskbar, mute, stop video, security, participants, chat, new share. Like I have like 15.
Interesting.
But that's not one of them. So I was just trying to find anything that said display. So
Okay. Yeah, what are these ones at the bottom say? What's that one? Toggle subtitles. What's under more?
So if I could give a quick suggestion from the audience, Michelle,
Yeah.
if you stop sharing and then if you, without sharing, put your PowerPoint to presentation mode, like so it's all on one screen.
Got it.
Minimize the presenter view, and then when you go to share the screen that has the PowerPoint up how you want us to see it.
Is that better?
Yes.
That's perfect. Thank you, Jenny. Thanks, Michelle.
Thank you. It's the same for me, but I'm glad it's working for you all.
It takes a team. Look at that. You girls did it.
Yeah. Thank you so much for that. I was about ready to give up. Technology is not my gift in life, so I appreciate the help. So I am Michelle Robinson. It's wonderful to be with you today. I really appreciated the presentation and was learning a lot. So thanks for that so much. I really love hospice and palliative care work. It's my favorite place to work as a chaplain because frankly, I'm introverted and I can do emergency care where I'm seeing one person every 20 minutes, but I much prefer the deeper, longer, more intimate relationships. And since I started that work, I just I fell in love. So I'm grateful to spend time with you today. I'm going to be presenting some concepts around spiritual pain, and it was also meaningful, exciting to me. Everything that I'm sharing with you today, it's really come from the past 5 or 6 years of research that we've gathered from a spiritual care perspective. So the objectives of my presentation today are to define and explore spiritual pain, to see how spiritual pain is linked to health outcomes, to consider how to integrate spiritual pain into tiered assessment models, and provide a case study to demonstrate some of the things that we're going to talk about today. So recent research has tried to tighten the definition of spiritual pain, which has historically been vague. Spiritual is a pretty nebulous term. So newer research defines spiritual pain as a self-identified experience of deep personal discomfort tied to meaning, purpose, beliefs, or connection. In a 2025 concept analysis refined this further, describing spiritual suffering as disruption of meaning and identity, breakdown in relationships that could be self, others, transcendent, or all three. And it includes existential questioning, hopelessness, or a loss of integrity. With this, one of the big things to highlight is spiritual pain is no longer seen as just religious distress, which is a common misconception that I'm constantly having to educate on as a chaplain. It's now widely understood, as it should be, to address existential and relational fractures as well. So as we expand beyond religion, spiritual pain includes a loss of meaning or purpose, threats to identity and dignity, and struggles with those existential questions of why is this happening? Who am I now? What does it even matter if I'm dying? And this aligns with those broader concepts of existential suffering, not just faith-related or religious distress. Some of the common causes of spiritual pain are life-threatening illnesses, loss of identity or role, guilt, regret, or unresolved conflict, religious struggles, a fear of death or non-existence. Some signs and symptoms that we see are hopelessness, loss of meaning, anger at God or fate or the universe, desire for reconciliation in relationships, and existential anxiety. We do see a stronger evidence linking spiritual pain to health outcomes. Once again, most of this, all of this study information that I'm providing for you today comes directly from palliative care and hospice, specifically working with cancer patients. But the research demonstrates that spiritual distress can even intensify one's perception of spiritual pain, which we've just heard earlier in our presentation, and worsen overall symptom burden. Unmet spiritual needs are associated with higher psychological distress, depression, and anxiety, lower quality of life in cancer and palliative patients. So we see that spiritual pain is increasingly understood as total pain. So that's psychological, social, physical, and spiritual. It's not just a separate bracketed issue. And unfortunately, you're probably hearing this all too often, once again, preaching to the choir, but spiritual pain is often underassessed and undertreated, though repeated studies demonstrate its correlation to increased physical and emotional pain. So as we also journey into this thought of how do we integrate into pain management and interdisciplinary care, a 2025 Delphi study created best practice guidelines for integrating spiritual care into chronic pain treatment that demonstrates it improves coping and meaning making, strengthens those therapeutic relationships, and reduces the taboo around having spiritual conversations, which is a large part of our culture. Up to 60% of chronic pain patients reported that they wanted spiritual aspects included in their care, even when they were not religious. So once again, we see that spiritual care is moving from something that's optional for patients to an expected component of what it means to have whole person care. Of course, with this, we have to recognize where there are systemic gaps in care delivery with this mindset. Spiritual needs currently are rarely assessed systemically and often neglected in clinical settings. Some of the barriers that were reported by clinicians are that they have a lack of training, so they don't feel comfortable approaching the subject or feel that they're appropriately able to assess. Time constraints, because a lot of things connected to spirituality do require more of a narrative approach. And then a fear of opening Pandora's box. Like if I lift this lid, what's going to fly out? How long is it going to take me to address this? And then our larger scale surveys show that there is an ongoing need for training, for frameworks, and for institutional support around this. In short, the field is conceptually advancing quicker than the practice is changing. Some emerging areas that we see is that there is a greater need to take interdisciplinary ownership. Spiritual pain is no longer seen as just a chaplain territory, as well as seeing the cultural and the global perspective, which increases our attention to non-Western spiritual frameworks and cultural differences in meaning making and suffering. So what now? So the past 5 years of research have really move spiritual pain from an abstract theological concept more to clinically relevant, measurable, and essential components of patient care. The biggest challenge now is not defining spiritual pain, but actually how do we integrate it into our everyday practice, which is where I wanted to spend more of our time together today, knowing your expertise and background, and I'm assuming appreciation of whole person patient care. So one of the helpful things is considered a tiered approach, and we're going to talk about this for a little bit together today. There are what is one of the most widely supported approaches in recent research is through a tiered model approach for disciplines to use. There are universal screening tools that include questions like this of what keeps you going during difficult times, and are you at peace? What matters most to you right now? Any member of the clinical team can engage in these brief screening questions to identify possible distress early, because the earlier we get involved and address these things, the better the outcome. We have more focused assessments. These are conducted by social workers, nurses who have training, and palliative care clinicians. These assessments, there are tools here. I wish I had tons of time with you. I'd be happy to go through them, but I wanted to list just a couple of more popular ones there, such as FICA and HOPE. These are spiritual assessment history screenings that can help pull important information, and they will engage around what's meaning and purpose, sources of distress, and spiritual coping. And studies show patients benefit most when these screenings, as I mentioned, happen routinely and early. It tends to be that most patients, if they do get a spiritual screening, happens in the middle of a crisis or directly after. And patients aren't always so receptive to care when they're in those spaces because they don't know how to process, especially if they're feeling numb or in a place of shock with what's happening. And so if we can routinely re-engage this, that's what's most effective. Then there are more of kind of specialist assessments. These are completed by professional chaplains. The specialist assessment includes an in-depth spiritual history, theological and or existential exploration, and ritual or meaning-centered interventions that must be completed by a chaplain who is trained in these kind of care. A commonly used spiritual assessment tool is the AIM assessment tool, and I'm going to briefly go over this. Everything has to be brief today, just with the time that we have together. But AIM stands for Attention, Interpretation, and Ministry. And these are three movements that guide the assessment and intervention of the chaplain. So in the first step, we have attention. So we wonder what's happening. This requires deep listening and the ability to be present, to attend to patients' stories, emotions, and their spiritual and existential expression. The second step deals with interpretation. What does it mean, what they've shared? This is where the chaplain reflects on what they've heard and identifies the type of spiritual needs, the type of spiritual pain that's being expressed by the patient and or family member. With that, you'll see here in the circle, there is meaning and direction. So if you have a patient or a family member who's spending a lot of time asking, for example, why is this happening to me? That's the bracket that would be addressed, and we would spend more time working around goals. If it's self-worth and belonging, they might be asking or expressing, I regret how I've lived my life. If it's connected to belonging or connection, it could be more that like, I feel alone or I feel abandoned. This step requires clinical judgment to be able to interpret and reflect on the information that's shared, which is why we need professional chaplains to conduct these more specialized assessments. Professional chaplain is a chaplain who has completed at least 4 units of clinical pastoral education. That's what I do as a certified educator here at the Level 1 Trauma Center. And with our training, after a student has received their master's, completed 4 units, which is about a year if they do it intensively, then 2,000 hours of work in the field, they can apply for board certification to move toward professional chaplaincy. So they have a lot of work and theory that they've been able to integrate in order to help assess, intervene, develop, co-collaborate with these plans of care with patients to move towards successful outcomes. And then finally, the third step of AIM is the ministry. So what is needed? I have assessed, I've gathered all the information, figured out where the spiritual pain is and what the patient wants to address. Now what's needed, and this is the intervention phase where we might address things such as meaning making. Sometimes that includes life review or narrative work. Sometimes it's connected more to reconciliation, what you see, which would include things like facilitating forgiveness. It might include letter writing or helping facilitate conversation. It could be more connected to presence or community or prayer or faith support as seen through rituals. So the big goal is to move toward more measurable, standardized assessments. It probably won't surprise you that in chaplaincy, most of our research has been connected to more qualitative data. And so really we've done so much in the past decade within spiritual support to move toward more quantifiable measures. This is just one example of this model. There are specialized spiritual assessment tools that we are identifying that work better for specialized clinical settings. The PC6, or often known as the PC7, focuses on those palliative care domains that are chaplaincy specific and evidence-informed frameworks to assess spiritual concerns that we frequently see in palliative care. Spiritual pain is shifting from subjective and hard to assess to clinically documentable and trackable. And this is just one of the tools that we can use for that. I'll show you like a sample of what this can look like. So here are the themes, the core framework that we use in this model of care. And you can see that it shows those themes of domains of spiritual concern that are often named by patients and or family members if they do have them. On the right-hand side, you'll see that there's a scorecard area for that. So for people who want to have some kind of identifiable number to address spiritual pain, this is a great tool to use. It's based on the techniques adapted from the spiritual distress assessment tool, which we in my field call the SDAT, that a chaplain or a clinician can rate the theme that's present. 0 being none of this is supported by evidence, moving all the way up to 3 and 4, which would show there's a severe unmet spiritual need. So if you were looking for some kind of a way to measurably create a scorecard for when do we need to call in the chaplain or when is this so severe, this is a great tool and example to use for that kind of needs. Just wanted to highlight some ways that you can bring up things connected to spiritual pain to keep it in the forefront so that it is in fact considered as an interdisciplinary approach instead of just falling to a chaplain or not being addressed at all. So you can see within this that spiritual pain can become part of a routine symptom monitoring like pain or anxiety, things that we always check in with our patients and our family members about. And evidence shows that teams who name spiritual distress explicitly respond more effectively when it arises. So newer models emphasize that automatic referral pathways are what are most effective. While I love the PC6 and PC7 that I showed you, and I think it's probably the best practice, is it the most practical practice? Probably not, because it does require more time, more scoring, more deliberation and assessment around, is this a 1, is this a 2, is it a 3? So what I have shared more with my team that I think is more practical are these triggers. So I would coach my team of, if you hear statements like, why is this happening to me? Or I feel like a burden. Sorry, I had a tickle in my throat. If you observe the patient withdrawing, exhibiting despair or a loss of identity, refusal of treatment linked to meaning or concerns. And I would also just teach my team when working as a hospice chaplain, please don't ask if they want a chaplain. You might even say, I can't tell you how many times it's been said to me, oh, they don't need a chaplain, they have a pastor. So like my kind of sweet way to respond to this to get attention would be, well, they don't need an oncologist. They have a primary care physician. Chaplains are not the same thing as a pastor. We have clinical expertise and training and can do much broader assessments. And unfortunately, the word chaplain can trigger and misleading assumptions about what we actually do. And so that's a big coaching that I would always provide for my teams. It's just say, hey, we're going to have a couple different people from family services and support come by to see you. Let me come and introduce myself. Let me explain what chaplaincy actually is and do a spiritual assessment. If the family says, I think we're okay, we don't have any of those needs right now, that was okay, because later if a need did arise, we had already established relationship and they were much more likely to call me. When we made this simple 1-sentence change in how we addressed providing spiritual care in our team, the chaplain rate of referral went up by 30% on my team. So it's a really effective way to just really consider how we're using our language to talk about what it is that we do. I also did a lot of work on my team to help train non-chaplains in appropriate spiritual first responses, helpful skills for all clinicians. And I am likely preaching to the choir because so many of you do this all the time, but just allow me to say that presence and active listening, naming suffering instead of trying to fix it. This sounds really heavy. This is painful. Learning to tolerate silence, to avoid premature reassurances. Really, it's comforting our own anxiety instead of trying to address what the patient's actually holding, and utilizing those narrative approaches to understand rather than asking yes/no questions. That is really where the gold is if we're going to figure out where people's spiritual pain is. It's not in a checkbox. It's usually in the narrative. And evidence shows that it improves patient satisfaction when we address spiritual pain as a team. I recently was doing research on likelihood to recommend scores, and it won't surprise you to find that likelihood to recommend scores do not directly correlate with whether the patient got the physical outcome they were seeking. It's not based on the patient saying they had a perfect experience with us. Why do patients recommend us again after they've had an experience? If they felt like they were cared for. How did they feel about their experience with us? And that matters so much. Evidence also shows that this reduces clinician discomfort. Clinicians encounter really difficult situations and conversations, and they want to do it well. So the more that we can help train them how to address spiritual pain as it comes up and have appropriate conversations and referrals, it decreases their anxiety around that. And it increases likelihood of appropriate referrals. So cultural humility is also a big part of spiritual care assessment. Recent research emphasizes that spiritual pain is culturally shaped. So we need to learn to avoid assumptions about patients' religion, belief systems, meaning making. And I always like to say to my chaplain students, a lot of times the people with whom it's the most difficult to experience cultural humility are people who we think are like us. And so we often have the most assumptions about them. Oh, you're a Christian. I am too. So I assume I know what's important to you or what you want. You're a Buddhist. You're Southern. You're whatever the thing is, it's really difficult to take a step back and have humility around these things. And that's really where a lot of chaplaincy training can be to your benefit, because chaplains are skilled at assessing not only the existential, but how culture plays into that. How am I doing on time? Okay, I'm going to give you this case example and then do my best to wrap up so we have a few minutes to discuss. But just as a way to demonstrate this, I'm going to give you a patient who I'm going to call Ricky today. He was a Euro-American male in his 40s. He was an alcoholic, and he was diagnosed with liver cancer. Was one of my patients, and when he found his diagnosis, he actually got a shotgun and walked to the woods with the intent to kill himself. He decided while he was out there that this would cause way too much pain to his parents, who had already lost 2 of their 6 adult children. And so he decided that he would allow this disease to progress, and moved in with his parents. And that is where we met him on our hospice services. Ricky was religious as a child, but not as an adult. He wasn't sure he wanted to see a chaplain, he told the nurse. But I received this referral from my nurse after her visit. She noted that Ricky said things like, "I don't understand why this is happening to me, but I probably deserve it." Additional triggers that she observed for deeper spiritual assessment was he had increased agitation at night. He refused previously accepted pain medication because he said, like, what's the point? And maybe I deserve to feel pain. He withdrew from relationships, even though he moved in with his family. He stayed in his bedroom isolated most of the time. He was very tearful when discussing life review. And so the nurse referred a chaplain assessment. So when I met with Ricky, I'm going to walk this through AIM so you can get kind of a chaplain experience of what this looks like. But I began, number 1, with the assessment. When meeting Ricky, it's really important to me to help patients get grounded. I utilize polyvagal theory as part of what I do. I wish I had more time to talk with you about this, but it's a really holistic, mindful-based approach that it's a beautiful theory. But with that, you focus a lot on regulation, getting grounded, helping pay attention to the vagus nerve to move from sympathetic activation, where people want to move toward fight or flight, of how can I get myself to a calm enough state to be able to process what's happening. So I utilized narrative and emotional exploration with Ricky. He expressed a loss of meaning. He said, like, my life just doesn't add up to anything anymore. Spiritual distress, and saying that I think God's left me. He felt abandoned. And shame. He said, I probably deserve this. I did this to myself. I'm an alcoholic. I'm a bad person. I noticed some holistic cues when working with him. He had shallow breathing when he was discussing his illness trajectory. He had clenched jaws and fists when discussing his shame, and tearfulness that softened when he would discuss earlier childhood memories that he had with his brother. The core spiritual pain that I was able to identify with him was meaning disruption. So we had a life narrative fracture and how he understood his story. Relational ruptures. He lived with his parents, but he really didn't want to. He wanted to die alone in his home. He didn't feel like an adult when he was living in their home. Existential isolation. He said, I'm just alone in this. And then theological struggle as he felt abandoned by God. So number 2, after gathering that kind of information, we moved to intervention. As I mentioned before, I used a lot of grounding exercises to help Ricky moved to something calmer. We engaged meaning reconstruction. So I would offer some gentle reframing with him, such as, like, when you say your life doesn't add up, what parts still feel true to you about who you are? I identified some of the values that he had named or that I was able to observe in his life. Tried to engage in relational repair, asked him to explore dying on his own terms, what that might look like, what would it look like to involve his family in that conversation. I know you all know the great question of what would a good death look like for you. I engaged him in theological and existential support. Instead of trying to fix his beliefs, I would validate them. So saying, it sounds like you feel abandoned. That's really heavy, painful place to be, especially when you're dying. We explored his spirituality to help him move from embedded beliefs that were reactive to more deliberative adult theology. And then engaged his legacy work. So we did a lot around life review, and I would intentionally focus his life review on meaning threads rather than communicating his story to himself and others as though he were a failure. So with this over 11-month period, what we were able to achieve and the outcomes in ministry, observable shifts where that Ricky's began to state, maybe my life hasn't been perfect, but it mattered. He began requesting spiritual rituals. Speaking of that cultural change, like instead of being in his bedroom, I noticed that nature was really important to him. He lived in the country, grew up. One day I even brought like this cheap fishing pond, little kid swimming pool, and we set up and fished off the front porch together because that's spiritual, that's connecting, that's meaning making. And it also got him out, got him connected to nature, which was really important for his spirituality. He had increased openness with his family, moved back into his home where he did die alone, like on his own terms. His mindset really began to change. He began to say things like, there were good things about my life. Maybe I'm still part of something. So we saw theologically that connection to greater interdependence rather than feeling abandonment only. And we saw some embodied changes. So he had more relaxed posture during my visits, improved engagement with our care team, and decreased resistance to symptom management. So the interdisciplinary impact was really the spiritual distress directly impacted the physical symptom management with Ricky. And I saw this again and again and again with my patients. Just getting that to a place where it's quantifiable and measurable is the tricky part when it comes to spiritual care. So some of the key takeaways I hope that you're gathering today is that when this can be done routinely, when we're sharing together, when it's in a structured way within your team, and if possible, the more we can move toward narrative with this, the more effective it is. A higher functioning interdisciplinary team who's approaching spiritual pain with seriousness, as everybody's participating in spiritual screening, everybody's exploring meaning making, and those deeper spiritual assessments are definitely referred and given to the chaplain to intervene and discuss outcomes. When we're discussing in team rounds regularly, documenting and tracking, and then have a referral system in place based on triggers. I like to say to my students that spiritual pain is not the absence of meaning. It is the cry for meaning that has not yet been heard. And it's important to teach our teams how to hear it. And I appreciate your time today, listening and taking that in.
Thank you so much, Michelle. That was wonderful. If we could spotlight Judy and Michelle and I now, we're going to move into a little bit of a panel discussion and open it up for questions and thoughts from the audience. I think both of our experts and speakers did a wonderful job highlighting the different nuances with patients experiencing cancer-related pain or non-cancer related pain, treatment pain and things like that. The spiritual aspect, the physical aspect, the social aspect. There's so many different things that go into that pain experience. And I think you guys did a really great job highlighting a team approach and a whole person perspective on that. I'm going to pause before I start asking some questions. I would love to hear if anybody from the audience has any questions.
I have a question. I am just amazed, Judy and Michelle, on how your teams, the engagement of the whole team around the physical and the spiritual assessments. And how long does it take you to get the team on board with understanding that this is something that has to be done by everyone, that one person can't do it? Because it's so easy to be focused on your track and not be focused around, okay, even though I'm the nurse, but there's a sliver here that I'm hearing, or, I'm the aide, or, I'm the pharmacist. And so I'm the social worker. So, I'm dealing with, family engagement issues. So if you could describe that, it sounds like this whole evolving piece of this around what the patient needs, requiring the whole team, takes some time. So what are you doing in terms of training and getting people up to speed about this?
I'm going to let Michelle talk about that because she's done a great job in her presentation, and I'd like to hear more. It's not easy.
I don't know if I should thank you or not for that, Judy. But thank you. You're like, I'm gonna let her answer that. I think it's just constant. I don't think there's a time frame. For me, it's most important to get whoever my administrator is on board with the concepts and the idea, because if it's not supported by leadership, it's not going to happen. And so I would always spend a great deal of energy and effort developing that rapport with my leader and trying to explain how I can make this teachable, and the benefit that we would get. And it was just because, I mean, unfortunately, there's such a great turnover in hospice and palliative care work, that it's constant change, because there's constant change happening in healthcare. I wish I had something more hopeful, like, oh, they'll get it in 3 weeks, but that's just not the case.
Yeah, I'm so glad you mentioned that. We have such a workforce revolving door, and to get everyone in the same mindset. But I appreciate that what you're saying is it has to be a part of the culture. So it starts from the leader, and then making sure that even when you get new people, you're training them, you're reminding them, I like this, the sort of unstructured, we're in IDT, this is going to come up like a regular assessment piece, and not just a nursing report. So, thank you both for so much. I don't know, Judy, in your world, how does it look?
So coming from an oncology perspective, the teams are disease-oriented teams. And instead of the big team of a palliative care. And unfortunately, what I see in some centers is palliative care is a different team. So people are saying, oh, palliative care will take care of that. It really helps when palliative care is embedded, like in the oncology clinic with the colorectal team or the lung cancer team. And that way, physically, they are part of the team. And that helps to transcend the siloing that we see occur.
Thank you so much for sharing. Christina touched on that this week about the embedding piece, and that proximity helps with those conversations and all. So thank you, ladies.
So I do want to highlight one of the things Judy talked about was access to pain care. And from a bit of a social work perspective, that kind of pulled me in a little bit to one of the things we've run into in other than prior auths, which anybody who's ever had to deal with prior auths knows. But even medication assistance programs, like I know there's an MAP, medication assistance program, that provides medications for patients who are uninsured or underinsured. They don't cover opioids or any controlled substance, but they do not cover any opioids at all. And it is a huge, huge gap and problem I know for a lot of our clinic patients, that access. We've had patients, again, who are underinsured or uninsured, or maybe are undocumented as well, and don't have, and then have to choose between their medications, right? They have to choose, am I going to be nauseous or am I going to be in pain? Because I can't afford medications for both. And I think that goes into the experience of pain. And I think both of you again have highlighted that it's not just physical, it's not just spiritual, existential, it's not just social, but there's this intersection of all these things and experiences that go into pain and how individuals experience that. Um, even as those distinct experiences of physical, spiritual pain as well, where do you see the strongest overlap between the two in clinical practice?
That's a fascinating question, Lauren. I'm not sure I can point to like a particular setting or a particular disease entity or even gender. I think it's prevalent throughout and that we often don't consider it because we're just asking 0 to 10. And again, preaching to the converted, you all are asking those deeper kinds of questions. But in the hospital and in many clinics, it is, you know, the MA, medical assistant, who's taking the blood pressure and, oh, yeah, how's your pain today? 0 to 10. And that's what's in the chart. And then people don't act on it further. I will also mention you were talking about these medical assistance programs. Not only are they not available for opioids, but many of the mail order kinds of places like Mark Cuban and some of the other even Express Scripts, etc., they won't do opioids, so you can't get even a reduced rate. And Cover My Meds, some of the pharmacies, I work in Chicago, so we have a good number of people from Indiana. I've encountered numerous pharmacies in Indiana that will not use Cover My Meds for cancer, for pain medications, for opioids, and will not accept cash. So that is so frustrating. And the first time I learned this was, of course, on a Friday afternoon at about 4 o'clock when the pharmacist lets me know that I need a prior authorization. And this poor patient was only getting oxycodone and he had advanced lung cancer and was just not ready to sign up for hospice yet because he really wanted to try that last clinical trial. And honestly, he wanted to finish repairs to his house so because he knew he was dying and he wanted his wife to live in a house that was pretty much taken care of and wouldn't have repairs that need to be done. And when I said to this pharmacist, you know, I'm not going to be able to get a prior authorization at 4 o'clock on a Friday afternoon. Please, can we use Cover My Meds? And that's when she said, no, we don't use it. It's our policy for this chain. And then I said, can you just please let him pay out of pocket for a couple pills while I can get the prior authorization? No, we no longer accept cash payments for opioids. It was so frustrating. It was just, these are the kinds of things that break my heart for my patients. And really, I think it leads to moral distress for clinicians. I ended up working on this and was able to get it, but it was like 7 o'clock on a Friday night, right? So, and so the poor gentleman was going back and forth to the pharmacy. It disrupted everybody's life, and that is so common. So, Lauren, yeah, thanks for calling that out.
Yeah, and I can hear the distress even a little removed from the situation. I can hear the distress in sharing that story too. It is a problem. And then if we want to look at it through an ethical lens too, and how is it ethical where we're kind of pigeonholing patients to choose? Either you can have hospice and choose this path where you will have good pain management covered, or you could be in pain. And it's almost, you're almost taking away their choice. I know we talk a lot in our ethics committee about the illusion of choice, and how icky, for lack of better word, that feels as clinicians when we don't have those options, not because they don't medically qualify for them, or not because there's not a medical need or medical indication, or that's even the best practice, but because of the resource and because of the care gap and because of these discriminatory policies that are um, affecting access for patients who otherwise don't have the option of having that. So definitely probably could do a whole other conference topic on that aspect as well. But thank you for tackling that too. Um, I wondered too, just I know we've got a few more minutes. I want to open it up again to the audience if anybody else has questions or thoughts that you want to put in the chat or engage in conversation. We've got a few more minutes.
I will say, Lauren, you asked where there's the greatest overlap between physical pain and spiritual pain. The newest research out of that for spiritual pain for cancer patients suggests it is directly correlated to identity loss. That those two correlate most highly connected to physical pain for cancer patients. If that is helpful information for anybody on the team to know.
Absolutely, thank you for that. So I know again we've talked a lot about undervaluating pain as well, the whole aspect of pain. Tell me, and especially how spiritual distress can amplify physical pain can amplify other distress as well. So the question I think maybe isn't what to treat first, but how do we recognize both sooner or all of them sooner? And I was wondering if you guys could speak to that, maybe tips on what we could take back to our practice. Like, what is the biggest takeaway you want us to have on how do we address these things better and sooner and as a team?
I would like to just say, keep an open mind and try to, and again, I'm preaching to the converted, but use empathy. So that, if someone seems kind of obsessed about their opioids, is it because they've had issues with access? And so they're going to work really hard to not ever run out again. What are the concerns that they have, again, in their home? Their children, caring for them, just their social issues, and just again, don't just ask where is the pain, what does it feel like, and what's the intensity score. Is go beyond that. And I know it takes some time, and I know you all are doing it, but as you train new staff who are entering into this field, or as you are modeling for others when you do a consult, help others understand that this requires empathy and curiosity and non-judgmental conversations, because pain is so stigmatized, the treatment is so stigmatized.
Yeah, I love that, Judy. I think both in spiritual care and working in ethics, the main thing that we say in healthcare, right, is communicate, communicate, communicate would solve most of our problems. And it's not because people don't value it or aren't good at it, but most of us are spinning so many plates and trying to address everything that's so important that it's difficult to do. And that is still the answer. Like when it comes to addressing spiritual pain, we do know if you address pain early, that we have better outcomes. How do we address it early? We have to talk to each other. We have to all be in constant assessment, and that takes work. There's usually one chaplain per 50 patients on a hospice team. So there's only so much we can do and assess. So we also really do rely on our team to help us. We're going once a week or twice a month, something like that, sometimes once a month. So all that in between, we desperately rely on our team. I was once called by my nurse, and she was like, Michelle, I have done everything I possibly know to do to help this patient with pain, and she's still in excruciating pain. Can you please just go by? And so I was able to get by that afternoon. I did a couple of guided meditations with her, and she immediately fell asleep. It was spiritual pain, like what she was experiencing. And of course, the medications help, but it wasn't actually addressing the point of pain. And where it was coming from. And so the more we can work together, collaborate to actually figure out what kind of pain it is in order to assess and intervene appropriately. But that takes work and communication.
Thank you both. Well said for sure. And we are just about out of time. I just to kind of round us out, I want to say one, thank you to our experts. Well said, well presented. Thank you for fielding our questions as well. If we take anything from today, I think it's that treating pain well means seeing the whole person with a whole team approach and making sure none of their suffering goes unnamed. So thank you both for helping us name that and address that together.